Hello, my name is Melanie Queener. I'm a PhD student at the University of Mount Union, and I'll be presenting my capstone project today. My topic was artificial sweeteners as a substitute for real sugar, whether this is efficacious or harmful. Now here's just a general table of contents. I'm going to discuss on the topics of what I'm going to discuss today. I'll give you a clinical vignette of a patient that kind of inspired me to take on this question. Additionally, I'll lead into an overview of obesity, diabetes mellitus type 2, and metabolic syndrome. Then I will cover the methods of how I went about with the systematic review of literature, the results that I discovered, and then the conclusions that I drew from the results that I gathered. So first off is a clinical vignette, a new diagnosis of type 2 diabetes. Now this occurred during my 5th rotation in internal medicine. I had a patient who I was going to tell them they had a new diagnosis of type 2 diabetes. This is after they presented similarly to what I will discuss coming up. And I had to go in there and tell him that he had this new diagnosis and then what changes in his lifestyle needed to take place. So a little into his history. So he presented before I saw him for his annual physical appointment. He was a 58-year-old male that presented for his annual physical at his primary care office, which is where I was. He had a history of hypertension. He was on lisinopril, but he had a history of noncompliance and wasn't really up to date on filling up his prescriptions. His last visit was about 3 years ago, and over the last couple months, he did note that he was having maybe some increased fatigue. He was really hungry, urinating more frequently, and drinking a lot of water. He was very thirsty. Now he discussed these concerns with his wife, who was concerned, and she actually was the one who pushed him into coming for his annual physical. He attributed these symptoms to just age and prostate and things like that, but his wife was more concerned. He denied any chest pain, shortness of breath, any other recent infections or recent diagnoses in the last few years, new medicines, anything like that. So his past medical history, we had him for hypertension and no other real history there. Medications, like I said, he was on lisinopril, and he did take a multivitamin. We weren't sure the brand on that. His social history, he drinks about 2 to 4 beers daily. He did use tobacco. He used to smoke, but he quit 15 years ago. And he denies any other illicit substance use. He lives with his wife, and he had 1 child in college. And he works in an office as an engineer, 9 to 5, Monday through Friday. Now his review of systems, so he didn't have any weight change, fever, or chills, but he did have that fatigue. He denies any headaches, runny nose, congestion, or any nosebleeds or anything like that. Denies any chest pain, palpitations, or swelling in his legs. No cough or shortness of breath, but he does have that increased hunger and thirst, but no vomiting, abdominal pain, diarrhea, or constipation. He does have that increased frequency in urination, but denies any pain with urination or blood in his urine. No dizziness or lightheadedness, or any numbness or weakness. No joint or muscle aches or bruising or bleeding, and no rashes noted. On his physical exam, he was mildly hypertensive, but his rest of his vital signs looked all right. He was alert and oriented, sitting upright in the chair, breathing comfortably. On his HE and T exam, though, his mucous membranes were noted to be mildly dry. And on his fundoscopic exam, we did see maybe some mild AV nicking, but no drusen or any other signs of diabetic retinopathy. His neck was supple without any lymphadenopathy. His heart was regular rate and rhythm, no heart sounds, murmurs, gallops, and his lungs were clear bilaterally. On abdominal exam, he had no distension, tenderness, or hepatosplenomegaly, anything like that, and he had some normal bowel sounds. His musculoskeletal exam, he had no edema of the lower extremities, and he had good pulses throughout, and no tenderness in the extremities as well. His skin was warm and dry, and he had no rashes that we could see. He was alert and oriented to person, place, and time, and he seemed to be appropriate in his affect. Now, differentials that we discussed, obviously at the time when I saw him, we had his lab work back, and I knew that he did have the diagnosis of diabetes, but prior to his follow-up appointment, the top differentials would be diabetes mellitus, dehydration with those dry mucous membranes. He was hypertensive, so we'll put that down as well. The increased urination did put us on the lookout for maybe some BPH, enlarged prostate, or maybe even a UTI, even though he wasn't having any dysuria or anything like that. So the diagnostics that I followed up with him on were the A1C level, the point of care glucose, which they actually took in the office, which was elevated, and then fasting plasma glucose levels. So his A1C was elevated at 8.9%. The diabetic range is usually anything above 6.5. That's going to be a new diagnosis of diabetes. His point of care glucose was 360, which is very elevated, and we like to see around 100 or so. And then his fasting plasma glucose was 140. Anything over, I believe, 126 will put you in that diabetic range as well. So the assessment plan that we overall did for him was diagnosed him with diabetes mellitus type 2. Now, after his initial diagnosis, we set him to follow up in 3 months for laboratory redrawing that A1C, see if it's coming down at all. And we discussed lifestyle changes. So I told this man about his diagnosis, told him about what needs to be done, the pathophysiology of the disease process that he does have, and we educated about carbs and discussed decreasing those intakes with your breads, your sugars, grains, things like that, and supplementing with good protein. Now, according to the American Diabetes Association, it does recommend the plate method and decreased sugar intake. Artificially sweetened beverages are still recommended as an option, however. And what led me to ask this research question was the patient asked if he could switch from his regular Coca-Cola, which he drank almost every day, and switch to a diet option. Now, at that point in time, I did not know that there was any negative association with any artificial sweeteners on any disease processes, so I told him that it would be a good thing in the acute phase to transition off of the sugar, but I did want to discuss with my preceptor just to make sure he wasn't aware of any up-to-date information about any negative consequences that could come from that. And from that, we also discussed adding medication, so we did start him on metformin, 500 milligrams BID. And of course, we educated him about the common side effects, GI disturbance being the most common. So that was the clinical vignette that actually led me to ask this question. Are artificial sweeteners efficacious, or are they harmful to the patient or individual in consuming them? So this is going to be the overview where I discuss just some background information about diabetes mellitus type 2, obesity, and metabolic syndrome. So for diabetes mellitus type 2, a normal body, sugar is allowed to pass into a cell using the presence of insulin, kind of like a key mechanism. When sugar is low, the liver breaks down the stored glycogen that is in the liver, and it turns it into glucose to keep the glucose level at a normal rate, so that the body and the cells always have glucose to use for energy. In diabetes, the cells become resistant to the action of insulin, or the pancreas is unable to produce enough insulin to combat this resistance of the cells. This causes elevation in the glucose levels in the body and leads to a condition we call hyperglycemia or elevated blood sugar. So this can develop at any age, but it is more commonly over the age of 40. But this is actually becoming younger and younger. And like I said, it occurs due to the impaired insulin secretion along with variable degrees of that resistance to insulin throughout the body. Early symptoms include thirst, frequent urination, weight loss, poor wound healing, fatigue, and hunger, much like the patient that I just discussed earlier. And complications are diverse, include vascular disease, peripheral neuropathy due to damage of the nerves distally, so a lot of patients will have numbness and tingling in their hands and their feet, and will actually walk a distinct way for a diabetic patient. They can have nephropathy, so kidney disease is also quite common, leading to chronic kidney disease, even the need for dialysis down the line. Infection rate, retinal disease. Like I said before, we did look at the patient's eyes to see if there was any sort of retinopathy due to diabetes being undiagnosed, with his last appointment being 3 years ago. He could have had it for a while. And many other disease processes. So diagnosis includes the previous labs that I discussed. So the hemoglobin A1C over 6.5% is going to put you in that diabetic range. The pre-diabetic range is around 5.5 to 6.5, and but some clinicians will actually say that's also falls within the diabetic range as well. A fasting plasma glucose level over 126, so our patient had 140, so that was well within the diabetic range, and with a following elevated oral glucose tolerance over 200. So treatment options, like I said previously, the American Diabetes Association does recommend the plate method. So just a brief description of what that is. One meal includes one non-starchy vegetable, so not a potato, which has a lot of starch and carbs in it. 3 carbohydrate foods, but like healthy foods, like grains and yogurts and legumes and beans and things like that. And 2 proteins, most recommended are lean proteins like fish. Even soy options are an option on a 9-inch plate. And it just gives a good breakdown as to how much food they're supposed to be consuming in a meal and what food types they're supposed to be eating as well. Other treatment options include obviously medication. We put our patient on metformin. That's usually the first line medication for any diagnosis, unless it's not really severe. GLP-1 receptor agonists, TZDs, SGL2 inhibitors, there's many others as well. And if it's incredibly severe down the line, even insulin therapies. Diet and lifestyle change. So as I talked about earlier with the diabetes plate method, and a lot of patients will also be drinking sodas and things like that, so it's important to discuss decreasing soda intake. But the American Diabetes Association does recommend switching to artificial sweeteners and water above all else. And then follow-up appointments. It's recommended to get an A1C level every 3 months or so, just to track the glucose levels in the body. The second overview topic is obesity. Now, obesity is characterized and quantified as a body weight index over 30 kilograms per meter squared, so a BMI over 30. And the prevalence as of 2019 of those who are obese in the United States is 42.4%. So, I mean, near half of Americans in 2019 were obese. So this is a fairly common disease process. The health risks associated with obesity: heart disease, stroke, diabetes mellitus, and certain cancers as well. And it is the leading cause of premature death that could have been prevented in the United States. And on average, medical costs are about $1,400 higher for individuals annually for patients with obesity compared to those without. So treatment for obesity, primary change is the diet change. So decrease saturated fats and decrease sugars, increase healthy foods, vegetables, fruits, and good proteins, and increase physical activity as well. There are medications that can help people with obesity. Orlistat, phentermine, GLP-1 agonists can all help in assistance with lifestyle changes. And also there is bariatric surgery as well that can alter the stomach size, bypass the stomach to help with weight loss as well. The final disease process I wanted to talk about was metabolic syndrome. This is characterized by many contributing factors: a large waist circumference, primarily due to excess adipose tissue in the abdomen, high blood pressure, abnormal fasting plasma glucose, so elevated, and dyslipidemia. There are many associated risk factors to this, including obstructive sleep apnea, non-alcoholic steatohepatitis, chronic kidney disease, diabetes mellitus, stroke, heart disease, the list goes on. Treatment is targeted towards the contributing factors. So, large waist circumference will be targeted primarily towards weight loss. And with weight loss, we target, diet and lifestyle changes. So decreasing fatty foods, increasing exercise, and many patients see that going to artificial sweeteners or low-cal sweeteners are a good way to cut out the pop and other caloric drinks like juice, things like that, and use that as a way to lose weight because they don't have the calories that they were taking in with previous drinks. Another would be high blood pressure. Usually with weight loss, blood pressure will come down. And then dyslipidemia, again, changing the diet away from saturated fats, which will also decrease caloric intake usually, and will decrease the fat intake, leading to hopefully a decreased level in LDL and the bad cholesterols there. So one key connection between all three disease processes, diabetes, obesity, metabolic syndrome, is the need for lifestyle changes through diet and exercise. Primarily even with diabetes, the association with obesity is there, so even losing weight can help in treatment. So with a need to lose weight, a lot of patients will go towards non-caloric drinks or even foods. So the artificial sweeteners are primarily thought of as in drinks, but there's also a lot in foods as well. And we'll see those as an option to cut down the calories in order to lose weight. But my question that I'm asking is that safe? Is that an efficacious way to lose weight, contribute to a healthier term in your disease process, whether it be diabetes, obesity, things like that? So moving on from just an overview of the topics we're going to cover, we're going to step into the methods of how I organized the research needed for this systematic review of literature. So step one for my methods would be to formulate a research question. And I use that based off the PICO model. The question being, are artificial sweeteners an efficacious and safe option for the treatment of obesity, metabolic syndrome, and type 2 diabetes mellitus? Or are they harmful? A total of 15 articles were used, and resources that I included to find these articles: PubMed, Medline, and Google Scholar. Additionally, I did pick an article. If I use that article, I would also look at the resource or the references that they use and go from there as well. Inclusion criteria for the articles that I used. I did use rat or mouse models, and additionally adult human male or female models as well. The articles that I included were published after 2006, primarily after 2010, but I did use the original or some of the original articles that were first highlighted this as an issue. They had to be published in English or translated into an English format, and they had to be peer-reviewed journal articles. Exclusion criteria that I used as well, articles that required subscription or additional fees, so whether you had to buy the article or subscribe to a specific journal, I could not use those. And then non-journal articles in the language other than English. Moving on to the results section, I'll cover some of the highlighted and key articles that I found that gave me insight into answering my question. Now, this first study that I'm going to discuss kind of kick-started the whole look into artificial sweeteners for any negative consequences that they have. So the Ramazzini Institute kind of started this concern in 2006 with a series of studies that used aspartame as the artificial sweetener in the rat model. So the first study took aspartame, took 8-week-old rats, and gave them different concentrations of aspartame. They found that there was an increased finding of lymphoma, leukemia, malignant schwannomas in males, and transitional cell carcinomas of the renal pelvis in females. So the increase in malignant tumors, especially at higher concentrations, is what they found. To their next study, they decreased the concentration, so aspartame was administered 12 days old, and they gave it to them younger until death at different dosages ranging from 0 to 2,000 ppm. So significantly decreased the concentration, and they still found that there's an increase of malignant tumors, including lymphomas, leukemias, and mammary cancer. So The current recommendation dosage is 40 milligrams per kilogram, according to, this was done in the UK, and they calculated their concentration, even at the lowest dose where they found cancer, was at 20 milligrams per kilogram a day. So they were even finding with regular daily administration, there was an increased risk even below the recommended intake and consumption from the UK. So there was a clear dose-dependent correlation of aspartame and malignant tumors they found in rats. An additional study that brought interesting results was looking at atherosclerotic risk in artificial sweetener intake. So acetylsulfame potassium, or ACE-K, was looked at and its effects on plaque building up in the arteries. So what these researchers did is they fed mice a high cholesterol diet until they were noted to have some plaque buildup on the aorta. And then after that plaque buildup was noted, they then separated the two groups and gave one the artificial sweetener ACE-K in one group for 8 weeks, and then the other had no change in diet. The results actually showed the mice with the artificial sweetener ACE-K supplementation had worsening plaque buildup than the group that had no supplementation at all with the artificial sweetener. So further investigation was warranted into how this mechanism really happens, and they found that these artificial sweetener did not cause what they thought an inflammatory process. It did not cause that, but actually enhanced the lipid production in the liver, while simultaneously decreasing the beta oxidation in the liver. This led to an increase in the lipids that were flowing through the body, which then increased the plaque buildup on the aorta that they were analyzing. An additional result that they found, which leads me to the next section, is that there was no change in weight between the artificial sweetener group and then the control group, even though the caloric intake in the artificial sweetener group was significantly less. So this led them to call for more research in, does artificial sweeteners actually increase body weight? Because the calories in the control group were much higher than the artificial sweetener group, but they still weighed the same at the end of the 8-week period. Now this is one of 2 obesity related articles that I'm going to share during this presentation. This first one discusses the results from over 22,000 adults from the National Health and Nutritional Examination Survey, and this involved an intent to lose or maintain weight over 10 years. Patients were examined on annual wellness visits, and their BMI, intent to lose weight loss, and their intake of low-calorie sweeteners was measured at each visit for over 10 years. So the results showed that those trying to lose weight in just a 12-month period were more likely to consume artificial sweeteners. Additionally, those who consumed 2 different types of artificial sweeteners, whether drinks or food-based products, were more likely to be obese. So some conclusions that they came to was that there was a correlation with obesity and consuming artificial sweeteners. However, a limitation that I found within this study was that they did not discuss other lifestyle aspects like daily physical exercise, diet, occupation, things like that. But they did come to the conclusion that there was an association between the 2. Now this is an additional study that looks at the association between obesity and artificial sweetener intake. So these researchers analyzed the risk between artificial sweeteners and long-term weight gain over 10 years using the San Antonio Heart Study with over 5,000 individuals, both male and female. So what they found based on survey feedback was that consuming over 21 artificially sweetened beverages a week was associated with over double the risk of being overweight or obese. And BMIs were 47% greater among the individuals who consumed artificial sweeteners than those who did not. Additionally, dieting was strongly associated with the intake of artificial sweeteners, with 72% of dieters consuming artificial sweeteners regularly. They found that at baseline, those who diet gained more weight on follow-up appointments than those who were not dieting at all. In conclusion, there was a significant dose-response relationship with artificial sweeteners and being overweight, meaning the more artificial sweeteners that you documented that you took in, the more overweight they found you to be, which is not insignificant. Now, does this indicate that people who are overweight intake more artificial sweeteners, or are the artificial sweeteners contributing to the obesity that these people are experiencing? Now, moving on to the association of diabetes mellitus and artificial sweetener use. Researchers in India took two groups, both had already been diagnosed with diabetes mellitus type 2. Group A were given artificial sweeteners, Group B were not given any artificial sweeteners, and then they tracked their insulin resistance with the HOMA-IR calculator. They found that those who were given the artificial sweeteners had higher insulin resistance than Group B. Now, they concluded that in the presence of an artificial sweetener, insulin is still released, similar to that in the presence of glucose. But glucose obviously is not there, and no glucose enters the cell. Now, limitations to this study, it was interesting. There was no population size documented, and then the length of the actual study was not documented as well. So how long they gave these two groups, or the one group artificial sweeteners and the one without, I do not know. And that would be important to know, I believe. Now, here's an additional study looking at the association between diabetes mellitus type 2 and intake of artificial sweeteners. Now, these researchers took data from a European study, the E3N European Prospective Investigation into Cancer and Nutrition Study. Now, this included over 61,000 women and spanned over 18 years, from the years of 1993 to 2011. And what they looked at is artificial sweetener use regularly and for how long. They had these women answer questions saying always to never, and based on how much they use artificial sweeteners. And what they found is those who reported using artificial sweeteners regularly had an increased amount of type 2 diabetes mellitus compared to those who consumed rarely. And additionally, women who consumed artificial sweeteners regularly for at least 10 years also had an increased risk of type 2 diabetes mellitus compared to those who rarely used artificial sweeteners. Now, in conclusion, there is a likelihood that with both higher frequency and longer duration of consumption with artificial sweeteners, there is some association with type 2 diabetes mellitus risk. And while these conclusions and results are concerning, I think there may be some limitations in this study, meaning other factors that may contribute to diabetes development, like other lifestyle characteristics, obesity, genetics, diet. These were not necessarily accounted for or asked about. So other things can contribute to the development of diabetes, and those would be nice to know in association with consumption of artificial sweeteners in these individuals. Now, this study goes into some of the physiologic changes observed from artificial sweeteners in the mouse model. So researchers investigated the effects of artificial sweeteners on the gut biome. In the first part of the study, 10-week-old mice were given one of 3 artificial sweeteners, with control getting just water and glucose. Results from this part of the study, all 3 artificial sweeteners led to a marked glucose intolerance, but saccharin elicited the highest effect of glucose intolerance found. So in the second part of the study, they just used saccharin. The dosage was 0.1 milliliters of pure saccharin, and this was added to the drinking water. Now, of note, this is the equivalent to the FDA recommended daily dose for human consumption for saccharin. Now, they elicited also a high-fat diet to imitate the obesity model, and they gave 2 groups of mice a high-fat diet. One group was given that saccharin, that 0.1 milliliters in their drinking water, and the other dose was just giving regular water. And what they found with this was that impaired glucose tolerance was noted in the saccharin group after only 5 weeks. Now, the function as to this, they determined change in the composition and function of the intestinal microbiota, and this alteration leads to altered metabolic pathways, causing increased susceptibility to metabolic diseases like diabetes. And just of note, this case is also supplemented by an additional study from these researchers showing the evidence of this altered gut biome involving a fecal transplantation of mice. Now these mice were exposed to artificial sweeteners, and then they had a fecal transplantation to mice that were not. And just after the fecal transplantation, the mice showed these gut changes, and the metabolic changes were seen, leading to increased susceptibility to diabetes. All of that research may be a bit to unpack. I'll provide just a brief conclusion slide. So the implications of the studies that I just discussed, one, there is a statistical correlation between artificial sweeteners consumption and obesity. Two, there's a correlation between artificial sweetener use and increased atherosclerosis risk, that plaque buildup in the aorta found in the mouse model, and cancer risk in the mouse model as well, with leukemias, lymphomas, mammary cancers, kidney cancers, things like that. Additionally, there is an increased risk and association of artificial sweetener use and diabetes mellitus type 2, going back to that physiologic change noted with the artificial sweetener use in the gut biome. Now, while these results do pose some concern for artificial use, there obviously are some limitations. Limitations to the research that I performed. There was only one researcher. It was just me compiling all of this research, going through articles and articles. I was unable to access all possible research due to the exclusion criteria that I listed previously, them being in different languages and costing subscription fees and things like that. Additionally, a lot of these studies used rat and mice subjects as opposed to humans. While this gives a great possible correlation to the human changes that we could see with artificial sweetener use, we're obviously not seeing it on the direct human itself. I believe it's definitely a cause of concern, seeing the tumor increase, the gut biome changes in the rat and mouse model, but we are not seeing them directly in the human model, so you cannot cause or correlate a direct change that way. Additionally, there were a few studies that used old data, one as far back as 1978 to 1989, for a newer study. So while the study was published after 2010, it used data from the 1970s to the 1980s to reach a new conclusion. And with that data, they did not design the study where that data was used, so all biases could not be accounted for, and all factors could not be accounted for, including like other dietary factors, other lifestyle factors, other comorbidities that these people had as well, and other medications that they were on were not accounted for, just their artificial sweetener use. Now finally, I want to spend some time talking about future recommendations and what to do with this information moving forward. So I think first and foremost, continued research, especially on long-term effects of people who use artificial sweeteners, seeing any long-term development of other comorbidities, including diabetes, obesity, heart disease, atherosclerotic disease, cancers, things like that. Having a documented artificial sweetener intake, as well as other lifestyle contributions like occupation, exercise, other diet intake, as well as other comorbidities and medications that they use. And I also believe that there should be some more research on the amount of artificial sweeteners that we have in our everyday foods. This was actually interesting. I tried to look for a study discussing this exact subject regarding the United States, but I was unable to find one. I did find a study on, there were studies done in Brazil and Turkey showing the amount of artificial sweeteners and sugars in their foods, in grocery stores and things like that on their shelves. What we found was in Turkey, 1/3 of the packaged products had added sugar or sweeteners, with the most common being sorbitol, which is one of those artificial sweeteners. In Brazil, with 4,800 packages looked at of different types of food, 66.7% contained either added artificial sweetener or sugar as well. Now that's concerning, but I would really like to see it on a more applicable sense in our own country as well. So definitely look into the distribution of artificial sweeteners in our own states. Additionally, I would like to change the recommendation for individuals and patients looking to cut down on glucose. Now, this goes back to some of those disease processes that I was talking about earlier. So the new diabetic patient, for the obese patient, or the patient with metabolic syndrome looking to lose weight and cut down on sugar, especially with the diabetic patient looking to cut down sugar from their diets to decrease their carbohydrate intake. I think it's imperative that we share with them that there may be some concern here with long-term use of artificial sweeteners, and that there are some hesitancies with using artificial sweeteners regularly. Discuss that this may cause an increase in weight gain. This correlation between obesity and regular artificial sweetener use, as well as even worsening their glucose intolerance. It could actually worsen their diabetes by using all these artificial sweeteners, and changing that gut biome and causing those metabolic changes within their own bodies. Additionally, on a brighter note, what I did find was 2 studies that I included here talking about stevia and monk fruit extract. Now, these are not part of the 15 studies that I talked about earlier in my methods section, discussing the inclusion-exclusion criteria. They were both published in 2020 and 2021, I believe. So stevia and monk fruit are actually shown to reduce hyperglycemia and improve lipid metabolism. So stevia in itself has shown to decrease LDL, total cholesterol, and triglycerides, while also increasing HDL in the rat model. And additionally, it has an antioxidant effect. It has been shown to improve caloric management and decrease body weight. So one of those resources you can give patients who, looking to lose weight, and then lower glucose levels in both type 1 and type 2 diabetes mellitus. Additionally, it does have antifungal, antimicrobial, and anti-yeast properties. One of the things that some of these diseases can cause is increased risk of infection. So having these additional helps could prevent infection down the line. However, one concern to note is that most stevia packages are packaged with an artificial sweetener. Stevia in itself, while sweet, does have an element of bitterness to it, so they usually compound it with an artificial sweetener in packaging. And because it is compounded with that artificial sweetener, there are the risks associated, as I previously discussed, with artificial sweeteners. So it's important to provide this option, but to exercise caution with regular and everyday use. I want to thank you for taking the time to watch my presentation regarding my capstone project of artificial sweeteners as a substitute for sugar. Are they efficacious or are they harmful? If you have any questions, concerns, please feel free to reach out. I'll put my contact information right here. Or email me with any questions that you have. Additionally, my references are on the next couple of slides as well. Thank you again.